My name is Adam Townsend, one of the founders of Vuit. My work husband, James Pratt, is the data side of Vuit. I'm the ops guy, and we've come together to produce what is now Vuit. I'm not going to do an introduction, just got a 1 minute, like 5 years we've been building to this. I've got a little video that'll just set out what that journey's looked like and then work on from there. Can you turn it on?
Vuit came to life in 2017 when James Pratt and Adam Townsend believed the national data sets they used to understand their clients' issues now need to collect data. Unfortunately, the shape and formatting of the published data wasn't good, meaning that without huge amounts of effort, most of it was retrieved. Adam and James decided there's got to be a better way to manage and protect these data sets, and so for the last 4 years, they've applied themselves to exactly that. During this time, Vuit has grown. We've added many more data sets, combining them to bring a completely new set of data analysis tools to market, all from the existing national data sets. Vuit continues to grow and improve, but today we can confidently say that Vuit.Online is one of, if not the best, population and health data resources currently available in England. Powerful, usable, scalable and valuable, and fully GDPR compliant, Vuit takes national data sets to the next level.
So that's us. We have been digging out, mining, harvesting anything that's available in the public domain and bringing it into a platform that's usable. Is it perfect? No, the national data sets are not perfect, but they're consistently imperfect because there is a really rigorous structure with which they're reported up. Is plus or minus 5% okay in Tim's world when he's measuring my troponins to see if I had a heart attack? No. Actually, if we're starting to understand how we can move our provision and move our capacity to where our demand is greatest, and to be blunt, stop people turning up to Tim's repair shop, because we're managing people and stopping them reaching that point where they exacerbate, it's probably good enough to get started, and that's where Vuit sits. We've got a platform that allows you to test hypotheses about where your population is, how it's being served, how that could be done better, and then move into, well, okay, if we can manage that better, what's the impact likely to be on colleagues in the acute sector? For the next bit, I need a really smart and intelligent and dynamic assistant. You'll do.
Yeah, you'll do.
So, 2 questions. Are you a data analyst or a data scientist?
Absolutely not.
Excellent. Have you spent an awful lot of time in Suffolk or North Essex?
No, I haven't.
Excellent. Right. So, I'm going to ask you a question. I want you to tell me where the diabetics are predominantly in that footprint.
I couldn't tell you, Adam. Could you tell me?
I could. And so could you. I'm just going to flick this way. So go and point on the map with red being a lot of diabetics.
Oh, right, okay. I thought you were
where
going
the
to point out
diabetics are in stuff. This is the ICB footprint.
I'm going to guess.
Red. Yes. Brilliant. Brilliant. So next question, just before I let you go. Can you just list off the GPs that serve that high density of diabetic patients?
No. Not yet.
Okay. I'm going to tell you a bit about that place just before we go to the next bit. So we know a lot about the 2,205 people that live in here. We know a lot about the population, how old it is, its ethnicity, and the long-term condition prevalence as well as loads of other stuff. Fundamentally, what we've now got for people who've never worked in the geography, who are interested in how that population's structured and how it's framed, we've got a picture. And we can work with pictures. We can all understand the thousands and thousands of data points that are behind this data because we've suddenly got a picture. So, you were going to give me that list of GPs? No, okay. So we've mapped the GPs over there to make it easy for us. So could you let us know broadly which GPs are serving that high propensity of diabetic patients?
Still there.
They're there, look. These.
I'm not really getting... We could have rehearsed
You
that.
see, we could have done it. Okay.
I really don't know.
So these are the GPs that we now know are working with our highest density of diabetic patients. We know a lot about the demographics of that population, and we now know that Clacton Community Practice is working right in the middle of that patch. And from a CQC perspective, it requires improvement. This might be a practice that needs help. So now we're going to go into the next level of data that says, what do we know more? Can we tell us more about this practice? Why might it be struggling? Well, actually, we can see that its GPs per patient ratio is quite high versus the national average, and a high percentage of its GPs are locums. So that might be a challenge when we're trying to consistently manage people with long-term conditions. And from a CQC perspective, there's challenges. We can see that from an accessibility perspective, it's not as good as the peers in its PCN. This is Ipsos Mori data. And over here, this is the long-term condition management indicators from Fingertips, Public Health England. And that's overall. And then we can drill into another layer. So I didn't know this till we started mining this data. GPs actually fit under 6 additional domains. So not just the 5 that we typically see in acute provision. So we can actually see that collective community practice hasn't been rated against those, but its neighbouring Caradoc surgery has got some challenges around its provision. And it's in a PCN that sits in an area that has a high level of diabetes. This is the just for respiratory. So, excuse me. How good are they at managing respiratory? So we've isolated just here, just the respiratory markers. And this is the diabetes, where actually, you know what, for a practice that does have some challenges, they're working really hard to manage that diabetic population, which is great. We see a lot of instances where that's the inverse. We can also see from the data that's freely available in the public domain, if you can lift 70 million rows a month of prescribing data, every prescription that's written by every GP in the country. And that's interesting. It's useful to some people, some organisations. And here we've just isolated down. We have every drug right down to the dose that's prescribed in every GP practice. So here we can look at respiratory drugs. We've isolated all the way down to the number of prescriptions and the cost of that PCN's prescribing. And actually, Clacton Community Practice over the last month has issued an average of 1,141 prescriptions for respiratory drugs, which are Tim, I can't say that. Thank you. I won't pick on you again, Tim, I promise. This is interesting. However, knowing how many drugs of a certain type are prescribed by a GP it's interesting. It might be interesting if you fasten it to other information, certainly when we fasten it to long-term condition prevalence. So we can see variation in, for example, the number of bronchodilator prescriptions that are written per person registered on the asthma list with the GP. Bearing now we are pulling information from over there somewhere and over here somewhere and sticking it together in the back end of what I'm showing you so that we can visualize it. So if we've got respiratory conditions and we're getting that wrong, or we're under prescribing, over prescribing, the knock-on effect can be that we see that demand that's not being managed well in primary care or in community flushing into the acute. And here we can see, I've just picked out respiratory systems and procedures in respiratory for Suffolk North East. And we can see the cost of activity just in this trust, £21 million in the year, 11,620 episodes at an average cost of £1,700. So that's a quick, this what we've built in Vuit is a subscription model. You can buy a subscription, log in, test your own hypotheses using these drop downs for any ICB, ICS in England. So that's great, Adam. It's lovely to like it. Love the pictures. Actually, if you come outside later now, we've got it working. We can sit you in a cinema and you can see it that big. That's great. So what? So what? My personal favourite, if you've got young children, you'll know who this is. This is Bluey. Yeah, if you haven't got children and you've got a quiet moment, watch Bluey. It's amazing. This is my hero, the unicorse. And his favourite saying is, "And why should I care?" Because moving people who should not be in hospital through that hospital quicker is not the answer. Yeah, waiting for secured clinical data sets to come, for shared care records to come, waiting for AI to be usable to the point that we can make informed decisions. We're getting there. But this is all there now. It's just, going back to the video, really horrible to manipulate. 5 years we've spent trying to crack some of this stuff. Is it good enough to make a clinical judgment about someone's health? No. Is it good enough to say, for example, if I've got a diabetic nurse at my disposal, if I ask the chief exec or the chief operating officer of the acute where they put them on the diabetic ward. You show them the picture, it's like, well, no, actually, because actually if I let them work with those 6 practices, they could probably keep me a nurse's worth of people out of hospital. And the outcomes for those people and the wider burden that those people will not now place on the health economy is massive. So why is that important from a health perspective, that reason? Why is it important for medtech, for innovation? Because actually this gives us the opportunity to articulate the benefit of our amazing widget, that reduces metformin for diabetics by 20%. Well, that's great. It's amazing, isn't it? Yes, it's amazing. And the clinical benefits are documented. Brilliant, right. So how do I pay for that then? Well, it's £1,000. Right, okay. So how am I going to get my £1,000 back? Well, let me tell you, because these 5 GPs here that work with your diabetics are where we're going to start. And last month, these 5 GPs spent X £1,000 on metformin. 20% of that is this much. And by the way, by managing these people with my amazing widget, 10% of them have been clinically proven to not exacerbate and require acute care. And I'm going to stop doing that because now I'm not caring. And that's important. And if 10% of those people don't have an episode in the acute hospital, so as innovators, as people that have got amazing things, but lack a language that we can use to articulate the benefit to the system. So we're not asking for more money, we're asking for less of different money. That's powerful. And I was going to show it, I haven't got time today. We've actually built, we showed you some of the GP information. We've built a website called Right GP for Me. It's in the public domain. You can put your postcode in. It will show you the closest 10 GPs to where you live. And it will show you all of that information. And you can make an informed decision based on the needs of your family as to where you might best register. Getting registered, another challenge, but fundamentally, with a population that can migrate to the service provision that's best at delivering what it needs, be that mental health, etc., etc. Yeah, that's the sort of thing. That's the business we're in. That's the shape of what we do. I'm just going to flick back here because there was somewhere I put 2 more minutes. There we go. We're growing, we're exploring new data sets. This is the latest data set that we've tapped into. This is the DWP data. This is the data set that scared me because this is where we went, oh my God. There are 2,613 people in that little blob there. There are 49 households that have got 3 or more children and claiming universal credit. And we know an awful lot about the demographic of that people as well. Where we can see people who are claiming wheelchair allowances, disability allowances. The DWP data, when you overlay it with health and population data, starts to identify different populations, at-risk children, people with low-level musculoskeletal challenges who actually, with the right support, could become a productive element of the workforce again. But we don't know where they are. We don't know where to go first. So as we layer these information sets on top of each other, we end up with really rich pictures. And I come back to the pictures because if you're the chief exec of an ICS or an acute, I could show you these data tables all day long and it would be incredibly difficult for you to engage with them. If I show you this picture and say, actually, as a provider of vulnerable children's services, where are you going to put your services? The business case speaks for itself. So hopefully that's told you a bit about what we do, who we are. I'm now losing my voice. And hopefully I've shown you a bit about what we do, but critically, so what? The last thing I want to say is, we've made a commitment, and I know Claire's spoken with people who are in the room today, but I just want to reinforce it, that those 4 billion data points that we've got sitting up in our cloud, looking after them, not looking after themselves. James would kill me for that. How long? 1 minute? 30 seconds? 30 seconds. If any educational organisation or academic organisation wants a feed to our data, you can absolutely have that for non-commercial purposes. So if you've got students who want to run projects with real-time contemporaneous data, you can have it. We will give you a log on to a IP feed to our SQL server, and you can use that. It's not selfless. We will get people who start to use our tools, and you may well breed the future of Vuit as a workforce. That's fantastic. But if we've got all this information and we've got to earn a living, we will have commercial models for this. But if you want to use it in a non-commercial way as an academic organisation, it's yours. You just have to ask. Thank you.